of an outpatient antimicrobial stewardship program. Mark is the program director of ambulatory pharmacy with Northwestern Medicine Physician Network, a greater than 3,800 physician member ACO with approximately 450,000 managed lives. Mark received his Doctor of Pharmacy degree from the University of Illinois at Chicago College of Pharmacy in 1988. He completed a general clinical residency with a focus on ambulatory care, internal medicine, and psychiatry through the Jesse Brown VA U of I Hospital in Chicago. He's held various roles in acute care hospitals from staff pharmacist to pharmacy director. His previous experience includes 8 years of health system pharmacy, ambulatory pharmacy management with the Advocate Aurora Healthcare ACO, and 7 years with CVS Caremark Corporate. We also have Dharmesh Patel. Dharmesh is the clinical quality leader with Northwestern Medicine, focused on improving care in the outpatient settings. Dharmesh received his Master of Business Administration degree from Ohio University in 2019, his Bachelor of Science in 2015, and Nuclear Medicine Technology Associate in Applied Science in 2008. Dharmesh has been part of the Ambulatory Antimicrobial Stewardship Committee at Northwestern Medicine since 2018 and has been facilitating outpatient committee and related activities. He plays an integral role in developing and implementing interventions in the outpatient setting, and more importantly, sharing individual clinicians' prescribing data and comparing that to their peers. So welcome both, and we look forward to this presentation.
Well, thank you so much, Jamie, and good afternoon, everyone, and thank you for the opportunity to present this session. My name is Mark Gregg, and as Jamie mentioned, I'm a pharmacist by training and the program director of ambulatory pharmacy with Northwestern Medicine. My co-presenter, Dharmesh Patel, and I would like to share with you our organization's way of implementing and conducting an ambulatory antimicrobial stewardship program. Dharmesh will focus on specific work involving our immediate care centers. And we'd like to both emphasize that this is a way and not necessarily the way to implement a program. What your organization's program looks like may be similar to Northwestern's or may vary based upon your organizational needs, goals, and resources. Last week, on July 6th, JAMA Open Network published an article by Sarah Keller et al. Entitled Assessment of Changes in Visits and Antibiotic Prescribing during the Agency of Healthcare Research and Quality Safety Program for Improving Antibiotic Use and the COVID-19 pandemic. What a title. In any case, it's a long title, but I would encourage you to read the article, and I placed the information in the chat. One of the key comments that I really noticed was little is known about implementation of antibiotic stewardship in ambulatory care practices. Another recent IDSA publication indicated that less than 10% of health systems have an ambulatory antimicrobial stewardship program in place. So our session is very timely. Next slide, please. The learning objectives are stated on this slide. Next slide, please. Northwestern Medicine is a health system with 13 hospitals, 512 outpatient facilities, 72 primary care practice locations, and 25 immediate care centers across the Northern Illinois area. Next slide, please. Northwestern Medicine Physician Network, abbreviated NMPN, is an accountable care organization. This is also the population health management team here at Northwestern Medicine, and I am part of the population health management team. Our ACO includes approximately 450,000 patients and 3,800 physicians. Care plans include the Medicare Shared Savings Program, Medicare Advantage, commercial plans, and our employee health plan. Next slide, please. So why is ambulatory antimicrobial stewardship important? Well, 80 to 90% of antibiotic prescribing takes place in the outpatient setting. 28% of those antibiotics may be unnecessary. The July 6th article by Keller et al. That I mentioned previously report up to 50% of antibiotics prescribed in the ambulatory setting are unnecessary. 2.8 million antibiotic-resistant infections occur each year, and more than 35,000 people die each year from antibiotic-resistant infections. Although not listed on the slide, antimicrobial adverse events are also concerns. This topic is near and dear to my heart, as my own mother died in 2004 from complications related to Clostridium difficile infection. And I assume that appropriate ambulatory antibiotic prescribing is also near and dear to your hearts since you're attending this session. Next slide, please. Northwestern's entrance into ambulatory antimicrobial stewardship began in 2016 when the CDC issued core elements of outpatient antimicrobial stewardship. And I'll be referring to this publication throughout my remarks. Back in 2016, Northwestern was coming together as an integrated 13-hospital health system, and there were many pockets or silos of ambulatory antimicrobial stewardship taking place, but nothing really standardized or consistent. The Northwestern Medicine ACO includes 2 large employed physician groups and a large number of independent physician practices. And in 2016, ambulatory antimicrobial stewardship was not a priority, and that led to the need to create and introduce such a program here at Northwestern Medicine. Next slide, please. I believe one should never assume anything, so let's start off by defining our terms, and these terms are included in the CDC guide recommendations from 2016. I suggest including this definition in your charter or other key documents so that if one of your team members are called upon to provide an elevator speech describing your program, that these terms are handy. So, in other words, antibiotic stewardship is the intent to. Sorry about that. Antibiotic stewardship is the effort to measure antibiotic prescribing, improve antibiotic prescribing by clinicians and use by patients so that antibiotics are only prescribed and used when needed, to minimize misdiagnoses or delayed diagnoses leading to underuse of antibiotics, and to ensure that the right drug, dose, and duration are selected when the antibiotic is needed. Next slide, please. The CDC's 4 core elements for outpatient antibiotic prescribing are listed here. They are commitment, action for policy and practice, tracking and reporting, education, and expertise. And this presentation will cover how to incorporate these 4 core items into your program. Next slide, please. Let's start off with commitment. The CDC has a template documents that may be used, and some of our speakers this morning did reference them. The CDC website is an outstanding source of physician, patient, and other antimicrobial stewardship documents. Your organization may choose to use the CDC's or perhaps create your own. Dharmesh will be sharing specific details on using patient education and awareness tools during his section. So, action for policy and practice. Your organization, identify a single leader to direct antibiotic stewardship activities within a facility. Your organization may have an ACO medical director, an infectious disease physician, or another key individual designated as the initiative leader. Another option is to have your ambulatory antimicrobial stewardship committee be the lead group within your organization to coordinate this work. Also, to include antibiotic stewardship related duties and position descriptions or job evaluation criteria. Northwestern Memorial Hospital and the Northwestern Medicine Community Hospitals have had very robust inpatient antimicrobial stewardship presence for many years. The bulk of inpatient antimicrobial stewardship work is done by the frontline inpatient pharmacists that are supported by the respective ID pharmacist or clinical coordinator. Our practice-based ambulatory primary care and other specialty area pharmacists also provide antimicrobial stewardship support, and this is included in their job descriptions. At Northwestern Medicine, COVID-19 has ushered in opportunities for ambulatory involvement for pharmacists and other disciplines through oral COVID medication and monoclonal antibody support for our primary care practices. It's also important to communicate with all staff members to set patient expectations. And I would just like to say that it's important for that entire ambulatory practice team to be on the same page to provide patients with a clear message and to support the program goals. This includes everyone from the receptionist at the front desk, the practice administration team, medical assistants, mid-level providers, as well as the physicians. Next slide, please. This slide provides recommended action for policy and practice, and I'd like to focus on items 3 and 4. Item number 3 is provide communication skills training for clinicians. Back in 2018, I attended the Illinois Summit on Antimicrobial Stewardship meeting that was held in Bloomington, Illinois, and also attended the session presented by Dr. Rita Mangione-Smith. Dr. Mangione-Smith presented on how to deliver the "you don't need an antibiotic" message to the patient using the two-part negative-positive treatment method. This led me to the idea of creating a video for our clinicians, showing them how to deliver the negative-positive treatment message. Dr. Jeffrey Linder came to the Northwestern Medicine Feinberg School of Medicine from Harvard in 2017 and was already a nationally and internationally recognized researcher on physician prescribing behavior, including ambulatory antimicrobial stewardship. He was invited to be one of our ambulatory antimicrobial stewardship physician champions. He was also aware of the negative-positive patient communication method. This led to the creation of a Choose Wisely video featuring Dr. Linder and a Northwestern Medicine team member. The video was filmed in a Northwestern Medicine practice examination room. Dr. Linder demonstrated how to deliver the two-part negative-positive treatment recommendation as described by Dr. Rita Mangione-Smith, as well as how to respond to a series of likely patient questions and comments. And Dharmesh Patel will touch on using the video as part of prescriber education in a few moments. Keep in mind, major prescriber concerns may include: how will the patient expecting an antibiotic respond if I do not prescribe one? Since we live in an age of Yelp reviews and patients' likelihood to recommend satisfaction surveys, prescribers have to balance appropriate clinical decision-making and delivering an effective patient message. Regarding the fourth item, our system Antimicrobial Stewardship Committee is working with our physician committee members to consider requiring the diagnosis to be included for antibiotic prescriptions when a potential viral illness diagnosis is made. The idea being that if the prescriber includes a viral diagnosis on an antibiotic prescription, that may cause them to reconsider prescribing the antibiotic after all. Next slide, please. This slide reflects the importance of having and sharing individual prescribing data with clinicians. Prior to joining Northwestern in 2016, one of my roles in my previous organization was to implement and conduct an academic detailing program for physicians. The experience during that time revealed physicians and mid-level providers are always interested in how they compare with other clinicians within their same medical specialty. The NM Clinical Quality Lead members of the Ambulatory Antimicrobial Stewardship Committee conduct academic detailing, including sharing prescriber-specific, specialty-specific, and geographic comparison data with prescribers. In my role, I attend monthly payer meetings and share with the payers how the clinical prescribers. I also share payer performance data and the work of the NM Clinical Quality Leads with various committees within Northwestern Medicine. Performance on payer measures is extremely important as this impacts overall organizational quality ratings, patient plan selection, possibly per member per month payment, and potential payer incentive dollars earned. Performance data may also be helpful with implementing an antimicrobial stewardship committee within your organization. Next slide, please. So Dharmesh will describe using effective communication strategies to educate patients about antibiotics when they are and are not needed in a little bit more detail. And I can't emphasize enough the importance of face-to-face educational training, also called academic detailing, in helping to address underperformance. That academic detailing can also be very helpful when you're looking to reward physicians that are doing the right things. There's nothing wrong with giving an attaboy, attagirl recognition to our physicians, because many of those physicians that are doing extremely well, you may wish to tap on the shoulder to be a member of your Ambulatory Antimicrobial Stewardship Committee, or to serve as physician champions to have possibly difficult conversations with physicians that are not performing on the measures as you would desire. I'd also like to emphasize the importance of providing patient-specific examples. Next slide, please. So how does an organization get the program up and running, and how do you get your team members engaged? Well, you have to ask yourselves a couple of questions. Where is the greatest need? Any hospital or health system in 2022 is looking for solutions to complex problems. Is it underperforming on antibiotic-related payer quality measures? is, are you seeing increasing antibiotic resistance trends? Are C. difficile cases trending upward? Are you seeing frequent immediate care center visits, ED visits, and other readmissions related to infectious disease, to antibiotic prescribing, so on and so forth? Are you seeing significant Medicare 30-day readmission penalties? Are you seeing racial or ethnic disparities in rates of antibiotic or non-antibiotic prescribing? I would just encourage you and challenge you to prepare a proposal for your ambulatory antimicrobial stewardship committee. To use the old expression, nothing ventured, nothing gained. Your audience will have two responses, either yes or no, but I would encourage you to submit that proposal. Next slide, please. Back in 2019, the Joint Commission released an R3 Elements of Performance document outlining expectations for antimicrobial stewardship in ambulatory healthcare. And as you may notice, many, if not most, of the items listed on the left-hand side of the slide are based on the 2016 CDC core elements of outpatient antimicrobial stewardship document. The Joint Commission R3 document may be used as another incentive or the nudge for your health system to implement an ambulatory antimicrobial stewardship program. Next slide, please. This slide will cover the various HEDIS and other measures related to ambulatory antimicrobial stewardship. Here at Northwestern, we currently focus on the three HEDIS measures listed on the top of the slide. And the Ambulatory Antimicrobial Stewardship Committee is currently considering implementing the CMS MIPS measure listed on the bottom of the slide as well. One way of defining measure performance is the quality measure score plus the financial incentive. Next slide, please. Depending upon your organization's population health payer mix, you may see one or more of these HEDIS measures included as payer quality measures. Your performance scores for these and other quality measures and possibly associated financial incentives will be monitored by your organization's population health team, quality committees, and executive leadership. 3 of the antibiotic HEDIS measures are included in this 2020 payer summary example. And I recommend including current and potential measure performance and potential financial incentive opportunity in your committee updates or program proposal. Next slide, please. Payers generally have monthly meetings with an organization's population health management team, and payers will provide monthly or quarterly measure performance summaries. This performance data is usually available at the provider level. An organization may use this provider level data to identify prescribers who may benefit from assistance with antibiotic prescribing. And by the same token, you can use this data to identify, who your stars are, who are your physicians that are appropriately prescribing antibiotic therapy. And these performance reports will also serve to demonstrate the value of your committee's work and to support the need for ongoing intervention. Next slide, please. The Antimicrobial Stewardship, Antimicrobial and Diagnostic Stewardship, ADSP website is used internally and is also accessible to outside health systems. The video featuring Dr. Jeffrey Linder delivering the "You Don't Need an Antibiotic" message that I mentioned may be found under the educational materials section on this website. Next slide, please. So who should you include on your ambulatory antimicrobial stewardship team? Well, I would suggest minimally you want to have a physician executive champion and also physician champions. These two are, in my opinion, your key drivers to make this effort successful. You'll also want to have representation from infection prevention, quality, pharmacy, your electronic health record, as well as your enterprise data warehouse. Since data is the key here, those representatives from the electronic health record and your enterprise data warehouse will be your key partners in putting your reports together. Next slide, please. This slide describes the current NM Ambulatory Antimicrobial Stewardship Committee reporting structure. And keep in mind, this process provides bidirectional flow of information. The Ambulatory Antimicrobial Stewardship Committee reports up to a system Antimicrobial Stewardship Quality Committee that ultimately then reports up to the Northwestern Medicine Healthcare Quality Management Committee. Next slide, please. And as I've mentioned before, I strongly encourage you to share your team's process and outcomes metrics at various internal meetings and with your payer partners. By communicating what your committee is doing, you may be successful in recruiting additional organizational leadership support, additional members for the committee, and securing additional resources. Next slide, please. This slide describes the NM process where the Ambulatory Antimicrobial Stewardship Committee reports to the System Antimicrobial Stewardship Quality Committee and also shares information at the Immediate Care Center Quality Committee meetings. The membership is listed, and you notice there is overlap in roles and attendees. Dharmesh will be discussing applying these principles to the Immediate Care Center Quality Committee in a few minutes. Next slide, please. So what's needed to get the program up and running? One has to understand their organizational dynamics. You know, who are the movers and shakers within your organization? Who are the key individuals that you want to be on your side to help advance your team? What is the main driver or drivers to overcome inertia? Someone has to have the vision. The organization needs to be ready. And as I mentioned before, COVID-19 has really done wonders to promote the value of ambulatory antimicrobial stewardship, as well as the work of our ambulatory pharmacists. In some cases, it also may be underperformance on payer quality measures and the loss of potential payer incentive dollars. Dedicated resources may include representation from infectious disease, primary care, quality, infection prevention, and pharmacy. And I can't stress enough the importance of having a physician champion. The physician champion does not need to be an infectious disease physician. It could be an internal medicine or a family medicine physician. NM examples include Drs. Jeffrey Linder and Stephen Purcell, who are nationally and internationally recognized researchers on ambulatory antimicrobial stewardship and are internal medicine physicians. The ability to report process and outcomes metrics is key to demonstrating the value of your program. Outcomes metrics will help validate the role and value of your committee, and outcomes metrics will also help to support securing additional resources. Next slide, please. This slide describes the process improvement methodology used at NM. DMAIC stands for Define, Measure, Analyze, Improve, and Control. DMAIC is also the process that drives Lean Six Sigma. And of course, there are other process improvement models available. I'd suggest incorporating the process improvement model used by your organization into your committee's work. Next slide, please. This slide describes some of the NM Ambulatory Antimicrobial Stewardship Committee meeting specifics. Each quarterly meeting is 60 minutes long. The same is true for the monthly, bi-monthly, in-between subgroup meetings. There may also be a need for ad hoc meetings. And I strongly suggest having a charter in place that describes the committee's scope, goals, measures, and participants. And with that, I will turn the presentation over to Dharmesh Patel.
Thank you very much, Mark. So that leads us into what are we measuring at Northwestern Medicine? And let me advance my slide, please. Okay. So we have developed 4 different measures as the Ambulatory Antimicrobial Stewardship Committee. There are 2 measures for children and 2 for adults. We're measuring URI for children aged 3 months to 17 years old, pharyngitis with a negative strep test for children aged 3 years to 17 years old, pharyngitis with a negative strep test for adults age 18 and older, and the last one is a composite measure of 3 different diagnoses: URI, acute bronchitis, and influenza for adult age 18 and older. We build these measures using HEDIS 2017 measure narrative specification and technical specs, and then we modify them to fit our organizational need. To be in this measure, a patient have to have an encounter diagnosis discreetly documented within the encounter, and of course, they have to have an encounter with a physician's APP within an identified specialty. And to meet the numerator, of course, they have to have antibiotic prescribed within the same encounter. These two pharyngitis measures on the right-hand side of the screens are a bit unique because not only clinicians have to have a documented diagnosis of pharyngitis, but patients also have to be tested negative using strep test. We are excluding patients with the competing diagnoses and a comorbid condition. So patients with the URI and otitis media documented in the same encounter are being excluded, and patients with HIV documented within the last 12 months are being excluded from these measures. After building these measures and validating the data, the raw data that comes out of it by ourselves, meaning clinical quality leaders, we share the granular patient level information with the individual prescriber from primary care and ICC, which are urgent care, but from this point on, hopefully I can refer to them as ICC, as Northwestern Medicine continues to call them immediate care centers. And this particular activity of sharing that granular level of information with the prescriber allowed us to ensure the accuracy of our data, identify the limitations of our reporting, such as free text documentation in our notes, and our inability to differentiate between a printed prescription and given to patients for travel purpose and the rest of the prescriptions. We also were able to take their feedback and make some of these modifications that are possible within our reporting structure. And overall, this activity of giving the individuals their own data, meaning prescribers their own data, helped us gain buy-in for this effort. Before we start any improvement work, we wanted to understand where we should be focusing our efforts. So we did a global analysis of eligible encounters and found that 56% of these encounters, the volume, is attributed to urgent care, and the remaining 39% was attributed to primary care. So we focused our improvement efforts on urgent care, ICC, and primary care. And we looked at a study that indicated that primary care clinicians do not see this antibiotic resistant and inappropriate antibiotic prescribing as an issue in their practice. And we knew this kind of information was out there. So we wanted to understand how clinicians in urgent care within NM see this as an issue or not. So we developed a one-question survey, and this is very important because we wanted to make it very easy for clinicians to respond to the survey and also garner a bit of an honest response. So we sent out a one-question survey to clinicians and discovered that the most common reason why clinicians prescribe antibiotics is because the fear of patient satisfaction. And we were really careful in phrasing the question. We wanted to not make it punitive. We wanted to garner a bit of an honest response and close the gap between intention and action. So the question was, what do you believe to be the most common reason why clinicians prescribe antibiotics for viral respiratory diagnosis? And if you think about this, it's not why, Dr. Smith, you prescribe antibiotics. It allows clinicians to think a bit more globally, and it's like, what do you believe to be the most common reason why clinicians in ICC or urgent care continues to prescribe antibiotics for viral illnesses? And to our surprise, the fear of patient satisfaction score was the number one reason. So following these findings, we analyzed a clinician's LTR, which is a likelihood to recommend, or patient satisfaction data, and antibiotic prescription rate. And we discovered that there is no correlation between LTR and antibiotic prescription rate. We shared these findings with our ICC clinicians, and this was really, really helpful and eye-opening for our clinicians, and even for us. Each of these blue dots in the figure shows the intersection between a clinician's antibiotic prescribing rate and their patient satisfaction rate, and with the correlation coefficient being negative 0.091. For this correlation analysis, we used the data for patients who only met the criteria for stewardship diagnosis. So patients who came to our clinics have had a visit with the diagnosis of URI, pharyngitis with negative strep test, acute bronchitis, and influenza, and following that visit, how they responded to the survey for clinicians. And that gets us into key interventions. All of these interventions are benign and do not interfere with the clinician's workflow at the point of care, meaning there is no hard stop when clinicians try to prescribe antibiotics. And these top two interventions, commitment poster and data sharing, they're designed from a perspective of behavioral science and have been proven to be effective based on the research done by our NM physicians, which are Dr. Linder and Dr. Purcell. And let's dive into every one of these improvement activities or improvement interventions one by one. So CDC commitment posters, a simple commitment to prescribe antibiotics only when it helps patients. We printed that in the size of 18 by 24, had all the practitioners, all the clinicians sign that in each clinic, and then posted in each exam room facing the exam table. This commitment poster leverages our displeasure with the cognitive dissonance. Clinicians, and we all in general, tend to dislike going against our own commitment, especially when that commitment is printed and signed by us and posted right in front of where we practice medicine. Also, this particular commitment allows our clinicians to shift the focus to a system versus personal, meaning as a system, we've committed to prescribe antibiotics only when it helps you, and it's not me, Dr. Smith, who's not prescribing you antibiotics, but rather as a system, we're trying to be more judicious in prescribing antibiotics, and we're only prescribing when it helps you. We started this work with the older version of CDC poster that you see on the left-hand side of the screen, but as time went on, we realized that there is an opportunity to improve this poster, and we wanted to make it simple, easier to understand, make it relevant. So we wanted to add a language of COVID-19, as that tend to be the most kind of like relevant or more recent thing, and flu information as well. And we wanted to make it easier to read for our patients. So when our patients are sitting on the exam table, they can quickly glance at this information and glean the importance of this. And overall, this also kind of sets expectation for our patients before a clinician walks into the room, that this is something that's, as an organization, we are committed to, and we may not be prescribing you antibiotics when it's not going to help you. We actually collaborated with our outpatient and inpatient antimicrobial stewardship committee, marketing and communications to draft this particular poster, and now is available and it's posted in all of our ICC. Again, that is replacing our previous CDC commitment poster, which we use for bulk of our work. Going into data sharing, we're using power of peer comparison by comparing individual clinicians' prescription rate with the overall region. The concept is kind of similar to energy report that you receive from ComEd or NICOR that compares your home energy usage with average from your neighbors and for the most energy efficient neighbors. So it allows you to see how you are being compared with your most efficient users within the group. We are also, so that's a particular scorecard we use for immediate care centers or urgent cares, and it has a denominator, prescription rate for that individual clinician, and then overall regional prescription rate. In an ICC or urgent care, we wanted to use a regional prescription rate because clinicians from, they don't necessarily have one particular practice they go to. They tend to kind of go all over the place within the region. Therefore, we wanted to have a regional prescription rate as an average. And in primary care, we used a little bit of a different concept when we shared the data at individual clinician level. And we only shared adult prescription rate with the other quality metrics that we share on a monthly or a bi-monthly basis. And again, this one includes a denominator for the particular to adult measure, individual prescription rate of their practice, and then top performance within the provider group as well. So this is a little bit different because primary care physicians don't necessarily travel to other practices. They have their own home base. So it allows us to kind of look at the practice level rate as well. And we also shared our regional level prescription rate. We are leveraging the competitive nature of our organization, our region, and comparing regional and specialty level data with our clinicians and our leadership. And this is an example of ICC data at the regional level. That leads us into patient education. What are we doing for patient educations? We use internally developed patient education pamphlets, Get Smart About Antibiotics, that describes the potential harm of inappropriate antibiotic use. We made this trifold pamphlets available to all of our ICC practice for patients to take home. It has a very patient-friendly language. And again, all of this communications are approved by marketing and patient communication, which has a center goal, one goal to make sure that we're actually putting out a patient-friendly language out there. More importantly, we're also displaying this message throughout our entire system, and it's only a digital message that goes out during the Antibiotic Awareness Week. We created this message through collaboration with our committees, marketing team, and patient communication team. This is the message that gets displayed in all of the NM digital displays. So when a patient visits one of our practices, then there is a monitor within each practice that kind of that shows some of the relevant messages, and we were able to utilize that to our advantage. We use this message during Antibiotic Awareness Week, and then continue to extend that throughout the flu season and the influenza season, which is in March 2022 in this particular year. For clinicians' education, as Mark was alluding to, all immediate care centers, or ICCs, clinicians were assigned internally developed 3-minute video that showcases physician-patient interactions. The video showed a physician explaining the diagnosis of viral illness, why an antibiotic prescription was not necessary, and expected duration of illness and symptom management options. And this particular video provides a scripting to our clinicians for patients who might be coming to our practices with an expectation of walking away with the antibiotics. And it highlights those 3-step process: review of physical exam and key findings with patients, present a clear diagnosis, and use a negative positive treatment recommendations that you don't need antibiotics, you don't have a bacterial infection, but rather here's what we can do, and offer over-the-counter comfort medicines or treatments. And again, we use our learning management system within our Northwestern Medicine to assign this video to all of the ICC clinicians, urgent care clinicians. We also facilitated a dialogue with our NM expert, which is Dr. Linder, with our ICC clinicians. So we would periodically have a meeting with Dr. Linder and rest of the ICC clinicians where we present relevant information and also give them an opportunity to ask questions and talk about specific scenarios. So all of this leads us into what were the results? Did it work or not? What you see here in the first line, the fiscal year 19, and then the data is accumulative data again. This is all of our stewardship diagnosis combined. So URI, pharyngitis with a negative strep test, acute bronchitis and influenza combined together. Fiscal year 19 is our baseline information. And at the time, our prescription rate for a cumulative diagnosis was 34%. And as a result, 15,417 patients were prescribed antibiotics. And at the time, our likelihood to recommend or patient satisfaction score, again, tying it back to the main concern of the clinicians from ICC, that their patient satisfaction rate could go lower if they are not prescribing antibiotics. So at the time, the baseline patient satisfaction rate was 82%. Following the interventions in fiscal year 20, the prescription rate dropped to 21%, 38% relative reduction, and as a result, we saw 8,982 patients receive a prescription of antibiotics, and patient satisfaction rate jumped to 88%, to 6% relative improvement. And in fiscal year 21, we saw additional reduction in prescription rate to 12%, 43% relative reduction. And as a result, only 3,684 patients were prescribed antibiotics, and our patient satisfaction rate was at 89% at the time. So overall, we started with a baseline of 34% prescription rate for all of our stewardship diagnosis, URI, pharyngitis with a negative strep test, acute bronchitis and influenza. And by the end of the fiscal year 21, that particular rate was reduced to 12%, overall 65% relative reduction. And our LTER, the main concern for our clinicians, actually did not see any negative impact. And this particular slide indicates the patient satisfaction and antibiotic prescribing rate correlations. It highlights the correlation between patient satisfaction and antibiotic prescription rate over calendar year. As you can see, we continue to migrate towards the ideal position on the graph, most clinicians having a higher patient satisfaction rate with a lower prescription of antibiotics, which is towards the top left side of the graph. And we now have this built into our dashboard where we can quickly go and look at this particular information. So let's look at the longitudinal view with the month-over-month prescription rate. Bit of an orientation of this slide. There's a lot of information here. Again, we're looking at cumulative data for all stewardship measures. Orange line represents a primary care prescription rate, and orange mountain in the background represents a denominator for primary care. Purple line represents a prescription rate for urgent care, and respectively, those purple mountains in the background represents a denominator for urgent care. Green shaded area represents the time we spent building these measures and developing the structure. We started our interventions in fiscal year 20, represented by the green dotted line with a flag here. And yellow shaded area represents an initial impact of COVID-19, where we saw prescription rate of antibiotics went up in the initial months of COVID-19 as clinicians were limiting face-to-face encounters and empirical treatment was being recommended. However, the denominator during this time, if you see this yellow area, the denominator was significantly lower, meaning overall, when you annualize the impact of this was very minimal, but it was eye-opening for us. In more recent months, you can see that we've seen the prescription rate continue to linger around 10 to 15% for both ICCs and primary care. And so therefore, we're thinking about additional interventions that are, that will interfere with the point of care at the point of care. And we're thinking a bit of an EMR enhancement. As an integrated academic medical centers, we track all of our improvement work. We present at various venues such as this one and publish our findings. We have presented this particular information at the Vizient Connection Summit and also at various internal NM venues as well. That leads us into key takeaways. Leadership engagement and comprehensive committee structures are important for implementing interventions and eliciting behavior change. In summary, what we've done is that we have addressed the clinician's main concern through data analysis and education, which is, again, their fear of a poor patient satisfaction rate. We implemented a couple of interventions modeled from behavioral science, which is a commitment poster and peer comparison, and reduced prescription of antibiotics and did not negatively impact clinicians' patient satisfaction rate. Organizations with numerous competing priorities should definitely think about these behavioral nudges that are relatively easy to implement and can have a really meaningful positive impact. We also looked at a diagnosis shifting performance. So this is to address the fact that over time, clinicians can learn to document better, to code better. Therefore, they will continue to do better in stewardship measures, but they will try to hide their codes for non-specific illnesses. So we did pull more of an all ARRT general diagnosis code for which antibiotics are appropriate and non-appropriate, and found that there was no diagnosis shifting occurring in our data. So next step, what are we doing next for this work? We're currently in the process, let me advance to the next slide, please. We're currently in the process of building our stewardship measures in EPIC and making them available within the population health dashboard. Population health dashboard will allow our clinicians to view their own individual prescription rate. And if they would like, they can click on the information and look at the patients that they prescribe the antibiotics for. We'd like to build our additional measure. So one of the other things that we're planning to do is that, as Mark was alluding to earlier, that we're going to build a sinusitis measure. So we're currently in the process of that, actually very early phase of that. And then for EMR enhancement, we're thinking of something along the lines of accountable justification, which again, Dr. Purcell and Dr. Linder have studied and found to be effective. And it's essentially a roadblock, or it's kind of a stopping point, which allows clinicians to kind of pause and think. And the way it will work is that when a system identifies a viral illness diagnosis within the encounter, it will trigger a message to clinicians when they're trying to prescribe antibiotics for that, and would indicate that this particular diagnosis does not indicate antibiotics, therefore please consider alternatives, something of that nature. Basically a hard stop when you're trying to prescribe antibiotics for viral illness. So we're currently brainstorming and looking at our system capabilities, and potentially would like to pilot it a couple of practices if we can. And of course, we are in the process of publishing all of this information, and hopefully we can have something soon for everyone to look at, and hopefully that gets published soon. And this leads us into our final slide, lesson learned at Northwestern Medicine. And Mark, will you be able to walk us through that, please?
Yes, thanks, Dharmesh. We'd like to close with a few key takeaway points. First off, the organization needs to be ready to implement the program. And having physician executive and physician champion support may be your infectious disease physicians, primary care, immediate care. That support is really critical. Prescriber and patient-specific data is needed, and you'll be working closely with your electronic health record and enterprise data warehouse team members. Clinician buy-in is also essential for success. Can't encourage you enough to share your data with outlying prescribers. And by the same token, you also want to recognize your prescribers who are prescribing antibiotics appropriately. And you may be successful with engaging those physicians doing the correct work by then becoming a physician champion and possibly having conversations with the underperforming clinicians. Physicians and clinicians in general tend to be very competitive, and they always want to know what is the person doing that's meeting or beating the performance goals. You also want to equip your prescribers with tools to prevent inappropriate antibiotic prescribing, such as posters, such as educational materials, such as how-to videos. And you want to obtain the support of your quality and your population health teams. And share your process and outcomes data with your internal audiences, such as quality improvement, infection prevention, population health quality meetings, pharmacy and therapeutics committee, and other external audiences. And as Dharmesh was wrapping up, to present and publish your findings, possibly at Illinois Summit, an antimicrobial stewardship meeting. Share what worked, what did not work, and other lessons learned. And Dharmesh and I would like to thank you for the opportunity to present this session, and we'd be more than happy to take your questions and hear your comments. And I see one of the questions in the chat is that when developing a program, should one focus on tracking certain antibiotics, antibiotic days, or total antibiotic scripts? I work very closely with Dharmesh on developing these measures, and Dharmesh, I'm going to defer to you.
Thank you, Mark. I think we can certainly, the one thing I would say, I think focusing on URI and acute bronchitis tend to be one of the biggest driver of prescription of antibiotics. Next thing that we've done is, pharyngitis with a negative strep. That's kind of unique, but focusing on acute bronchitis and URI, which I believe are the biggest driver within our findings, can be helpful. And building these measures can be a bit complicated, but if you would like to simplify a little bit, perhaps you can monitor the overall prescription of antibiotics for using a grouper in terms of like all ARIs, and see what you do overall over time, how you perform over time. But if you're trying to think about focusing on individual prescription or individual diagnosis, then acute bronchitis and URI would be the good starting points.
Thank you, Mark and Dharmesh, for that incredibly informative presentation on outpatient stewardship implementation. It doesn't look like we have any additional questions in the group, but I did want to highlight to the audience that Mark has included a reference to one of the articles that were discussed in the presentation. So check that out. We'll just give it a few more minutes to see if anyone else has any questions. The next breakout sessions are scheduled for 2:35 p.m. So for that, just head over to the sessions tab and just select the session that you are most interested in.
We'll stay on for a little bit, maybe, Mark, if there's any questions, comments. Certainly, we're happy to answer.
Yes, more than happy. Thank you. And we will be making our PowerPoint slides available.
I still don't see any questions in Q&A. Jamie, you let us know when you want to kind of end and give people probably a couple of minutes before they join the other session, so we can end whenever it's feasible now. I don't see any questions now.
Yeah, I don't see anything either. So we can plan to close out at 3:25 because that's when the next session will open up. And then I can help set the next presenter up as well.
Great.
Thank you so much, Jamie, for your help, and thank you, Dharmesh.
Of course, Mark.
Of course.
Shannon.
Thank you for listening today. It looks like we had about 50 or so attendees, so I hope that many people will take this back to their institutions. Imran Khan says, excellent presentation.
Thank you, Imran.
And for any of the audience members, you're actually welcome to hit the moderation tab on the bottom left of your screen and join in for a conversation with Dharmesh and Mark for a more personal experience if you'd like, if you don't want to just type a question into the chat. It's a really cool feature that we have. So I'm just going to leave this session now. It doesn't look like any more questions have come in, and we can all head into the next session.
Thank you.
And Mark, I will be part of Jamie's session.
Great. Thank you, everyone. Bye-bye.
Thank you.